Okay, hi everyone. We're about to get started. It's just going to be Dr. Williams today. 30 minutes, one question, one follow-up, and I'll turn it over to Dr. Williams for some brief remarks.
Yes, well, good afternoon. And yes, Dr. Yaffe's at other meetings, so I'm going to be doing the numbers and some comments on the numbers accordingly, so that we are getting close to finishing our 7th 14-day period. And that's a major achievement as we look at that and seeing what we're wanting to observe over the next 2-week period as we continue to monitor our progression in coming down the slope on various aspects of peaks and how we're progressing on that and making improvements. So as of 4 p.m. yesterday, there were the total number of 16,187 confirmed cases. The increase from yesterday is 459, or a 2.9% from the previous report. The distribution of males and females is the same as we've had before. And again, about 49% of our cases are 60 years of age and older. And still, from the cumulative number, most of the cases tend to be in the Greater Toronto area in that regard. We continue to see Ontarians recovering, and that's important to note, with 63% or 10,205 of our 16,000 have recovered. And that's a very good metric in monitoring there, and that number will only but increase as we go forward. Unfortunately, we still see people in hospital increasing, up by 22, and the number of people in ICU has decreased, by the way, slightly. I call that more plateauing. And ICU is also pretty well on the same line with how many on ventilator, moving back and forth with 181, while the decrease in ICU was 233, the total. And so it's pretty well the same as it was yesterday as it stabilizes. Some of the hospital increase, of course, is because we have moved some individuals from long-term care into hospitals, and they're waiting to see when they can discharge them back into the facility. So there's a little bit of an artifact that has to be considered in there as hospitals have stepped up to assist on the aspect of the long-term care outbreak. Tragedy, of course, we're still seeing deaths, and people who were infected a number of days ago, some weeks ago, have unfortunately passed on. And each one of these, of course, is an individual, and it is we shouldn't lose track of that. Each one, while there's numbers, are individuals that have family and relatives, and friends, and different things, and it's a loss. And we have endeavored to try and keep that number down. And so far, we've had 1,082 deaths, and 86 have been reported. Increase from yesterday's is accumulation of both from long-term care as well as from the community side. In the long-term care side there, we have 163 outbreaks. That's an increase of 4, and 835 deaths in the long-term care facility as a subset of the total I gave you before. That was an increase of 60 over the previous report. And we said we would be talking about retirement homes. We have 61 of the retirement homes are in outbreak. Their numbers, as I said, they're a bit different because they've had a decrease of 47 cases in residents and a decrease of 14 cases among staff. That more, I would say, is due to data rectification as they're getting into more of a formal reporting process. So isn't actually a decrease in the individuals. It's more of making sure there's not double counting and there's some mistakes in the numbers. And so they're doing that. And they've had an increase of another 6 individuals who were reported to have died in this reporting period increase. From the testing side, we've done now a total of 277,522 tests, and under investigation we have just under 11,859, and in the last 24 hours we've just done under 13,000, 12,928 tests completed in the last 24 hours. So that's a new high for us, and of course with the queue there and more coming in, we're expecting that number to even climb higher perhaps within tomorrow. And the number of healthcare workers cumulative since January, 2,292. That's an increase of 14% in there. And in fact, we've noted we've had now 3 deaths in healthcare workers in that. And that's part of our noting that these are all significant. And, of course, condolences to the family as we remember that and assess to see what has gone on in that situation there. So those are the numbers there. We look at them, and as I said before, if you look at it, and yesterday, as I said before, we had a low number, and I said take it with a grain of salt. Before that, we had one in the low 400s and mid 400s, and then we had one up in the 500s I said, take that with a grain of salt. So we're seeing this flow and back and forth of testing. I think that our number somewhere in the middle 400s, lower 400s is probably where we're really at trending. And again, as I was asked before, my data shows that in the entry that we're tracking about 50% of those numbers are long-term care. So that means our community one is somewhere in the low 200s, which is encouraging. And we need to continue to watch that. I think that probably some numbers the next few days will show even more percentage higher in the long-term care because we're doing a lot of sampling as we continue to test all the residents and staff in the long-term care facilities throughout the province, and we endeavour to keep at that fervently over the next number of days and weeks to complete the task in a timely fashion. So I think you're going to see that happening. We continue to watch how the trends are going and whether they're peaking in different areas. It would seem to be, as I said before, that some of our community numbers, we have peaked and sort of plateaued coming down slowly, and we want to see if that progression will continue, allowing the blips, as we've seen in the last few days, depending on lab tests flowing and reporting. And the long-term care, it seems to be some of the positive numbers there have potentially maybe peaked a bit, and we're watching to see if that's a true peak, if it's coming down, and both these fit with what our modelers had looked at, saying that our long-term care numbers would be behind our hospital numbers by 2 to 3 weeks. So we're looking at whether that will be true and whether we'll be peaking either with our deaths in long-term care homes, which would be nice to see that coming down fairly assertively sometime next week, and we'll seek to monitor that and advise you accordingly. So the next 2 weeks are, again, to say, okay, we've done our physical distancing. We're continuing to do that. We're looking at when we can start to open up things more. We wanted to see this progression, as we said in our framework, over a 2-week period, 3-week period of a steady coming down, not blips, but steady progression in those numbers, and ask our public health measures group to look at that, to assess where we're getting back into a matter of containment with aggressive case contact management, and to, at the same time, still want to maintain and bring down the issue of the outbreak in our long-term care facilities, making sure we're making a control on retirement homes, and then we have our congregate settings as well, as we're trying to wrap that up and watch that very carefully at the same time. So the next 2 weeks are, can we continue to see that steady decline? Can we consider having some changes, because that'll take us into about the middle of May? And I know that the Premier is hoping to make some announcements in some areas, and we have noted that some have moved towards some aspect of functioning by maintaining all the aspects of the social distancing, including the 6-foot distancing and other steps to minimize person-to-person contact. Excuse me. So that's the data there. So I'm going to hand over to questions.
Okay, we'll move to the phone lines.
Your first question comes from Colin DeMello with CTV. Please go ahead.
Hello. Did I just hear you say the middle of May? Could you just expand on that in terms of whether that's a date that we're looking at as a potential reopening for the economy, or at least maybe just a slight reopening of it?
I think you're reading further on the words I said. I said the next 2-week period, starting this weekend, will take us to the middle of May. So I was talking about the next 2-week period to see how we're going to progress on the slope continually coming down in our accumulation cases. So I think you were, like everybody else, optimistically hoping that might be the case, and I can't say for sure, but that's why I said the middle of May, because 2 weeks from this weekend will take us to about the middle of May.
Okay, I appreciate that response. Just another thing, all of the guidance that's going out to the to all of those sectors that was announced today, it does include this line saying that PPE is a last resort only. Can you give me a sense of why it's not mandatory for employees who come into direct contact with customers, why it's not mandatory for them to have PPE, and why it's a last resort only?
Okay, so because we're still in the pandemic phase, we're saying that in business and industry, we don't want you coming in contact with in public in that way. Can you operate your function with that 6-foot distance? Can you space out your individuals coming in? Can you put up barriers when you're dealing with retail and sales, so that those physical, those functional, those administrative barriers should be the first priority. If you do that, you should not have to be forced, and your staff forced to come in close contact with the public in that way, and the public don't have to come in contact with the staff. So PP would mean to say that you can't do that, or there's something that makes it improper that you can't meet that, and we'd wonder why is that the case, and do you have to delay or hold off on that if you can't maintain the majority of your work in that regard?
Next question.
Your next question comes from Lucas Meyer with News Talk 1010. Please go ahead.
Thank you very much. Hi, Dr. David Williams, for taking my question. I actually want to go a little bit outside of Ontario, looking at some international data. The United States is feeling very optimistic about, and I'm sure you know this way better than I do, remdesivir, the antiviral drug, after data showed that it helped patients faster than those that did not, and there might even be a push to make that widely available very, very soon. So I'm just curious, is this particular antiviral on your radar? Are you feeling optimistic about it? And can you speak actually to its availability here potentially in Ontario if it's found that this is something that's administrable and available in the United States, perhaps elsewhere in Canada?
So the idea of antivirals, we had initially a number of people were looking at anywhere from 8 to 10 different, up to 14 different antivirals that, of course, since the outset of this pandemic globally, to try and test to see would they be effective. I mean, our traditional ones we use for influenza, we have been told are not effective in that line, so that has been ruled out. I think these different ones, I understand the data is fairly new and of some limitations, so we hear that from them it's promising. It doesn't increase the percentages huge amounts, but any increase would be helpful if it's a true one. So we're going to be advised by further what they're doing. This actual product I hear is manufactured in the United States, so they would have access. I haven't checked in or know of its availability here in Canada, and whether our clinicians in our specialists at our top centers agree with it or don't agree with it. We have not been advised by them, and that kind of clinical management, we would depend on that expertise, not from my table in particular.
Okay, and my other question is about, and perhaps you can speak to this as well, Dr. Williams, this joint commission out of China and the World Health Organization that apparently could not find the case of a child passing the virus to an adult. I know there's a number of studies that have come out with regards to, how much it is in children, and it appears to not be that much. But about that specifically, if that's true, and there's more evidence that the transmission of children to adults just is either very, very low or maybe not even there, would that data influence your decision in terms of what we do with schools and how we open them in any way? The transmission element from a child to an adult, would that affect you in how you decide what's going to happen with schools?
Well, definitely. And the data that you're quoting, we've looked at it, and from a national level, we found a paucity of studies. There's not a lot, and the studies are fairly limited. So it's not really, I would say, really definite data that tells us something definitively one way or the other. So we're trying to get some better ideas on that. Children, of course, being relatively and sometimes totally asymptomatic and very mild, because it's hard to pick up these symptoms on them in that regard. And then could they actually have it for a period of time? How did they follow the studies there? Could they pass it back to the family, etc.? So we're trying to understand that and to be persuaded. Of course, we have our one outbreak at one of our centers, and we're asking for the results of see what Toronto Public Health has, if they identified any causal link in that, whether it's related to children or not. And so that's our one thing we'd have a chance to be informed on. We don't have a lot of data in Canada per se, and I don't see much from the United States as of this time. And so we are going to have to rely on some of those outside studies as some indication perhaps of what it is, but we haven't got anything definitive that our specialists would say it is certainly not a cause, or in that light, we have not heard that from them. There is a potential, low as it is, and so we take that into consideration of if and how we would open up our education systems daycares, etc., in that light, and we want to make sure we're solid on that, as well as I think the public and the parents especially would want to be satisfied with that data and information accordingly.
Next question.
Your next question comes from Cynthia Mulligan with City News. Please go ahead.
Hi, Dr. Williams. We have an echo. Do you hear an echo? I'm sorry if that's...
No, I think...
Yeah, I'm sorry.
Maybe you're hearing an echo, but we're okay here. Thank you.
You're okay? Okay, good. I'm happy to hear that. So last week or a few days ago, you said that you would like to see community spread drop to below 200. And you're saying now we're in the low 200s. How much lower below 200 do you want to see it consistently drop to?
So our public health measures said we would like to see a steady decline over a 2-week period. So we're seeing a decline over the last 5-6 days. So we want to see that go well below 200. Our R0 level is just barely nudging 1. We would like that a lot lower, and that's just that transmission level. We'd like that a lot lower than 1. And so we're going to be informed by a number of metrics in there in our public health measures group in that regard. So it's looking promising. We'd like to see this steady decline as we clarify the data. And going, as I said initially, I'd like to see it well below 200. The last time we had our levels of without community spread, our numbers, if you recall back then, the end of way back in the beginning of March, was usually 88, 100 cases, new cases a day. It was nudging up to there. Once we start to get to around 150, 160 heading over, we started seeing more and more community spread cases in that side there. So we have to get back to somewhere around there so that we can be assured that all our cases have been followed up and we can identify what was the source, where did they get it, what was the contact, and other ones in that line. So that assertive containment is very critical to relaxing the public health measures and to inform the public of the relative safety of social activity in that regard. So I hope that gives you the context, but we would like to be well below 200 to get us back to where we were in the early part of March, a while back, 6 weeks ago.
Follow up?
Okay, thank you. And I know you don't want to give a concrete answer of when the economy could open up again, and I completely understand. But just to give me a sense, if we're 5 or 6 days in a steady decline, and you want to see 2 weeks of a steady decline, are we almost halfway there of a 2-week cycle, potentially?
Well, 6 out of 14, getting closer. And we had a little bit of blip there with that high and then low, so we're trying to get the leveling. I think what we're trying to look at here is that before we go to that stage 1, other things can happen here if people maintain the measures, as in the 6-foot distancing, the proper protection and barriers and function, people and different ones that have been doing things like curbside pickups in different areas there. So there's things that still within this framework we see ideas and concepts around, and the Premier may be speaking about that coming up in the next few days about what we can do to safely allow some things to happen within the constraint of the existing public health measures. Then when we see the numbers drop low enough, then we look at the first stage, as we said in the framework, and that has some more definitions to come in there. But we're 5-6 days in. Excuse me, dry mouth. We're 5 to 6 days in. Let's see what happens. We've got to keep watching this and the blips and making sure we're separating long-term care from our community cases.
Next question.
With the Toronto Star, please go ahead.
Hi, Doctor. I will try not to echo. I'm wondering, when are we going to hit this 19,000 mark in the processing of daily tests? And is that as high as we're going to be able to go?
So, as we said, we're at just about 13,000. We have about a 12,000 pending and more coming in as we're doing all this testing. So I think we'll be continually rising over the next number of days as we even do even more testing in the long-term care facilities. So that will continue to drive up. Will we get to the 19 or 20,000? I think it is possible. Is our lab group we're looking at to go beyond that? They have some ideas of how they might do that. That depends on a number of components. So I don't think that's the end, but that's the target we're going for right now. And how we push that target up, of course, all depends on the samples coming in. And we're doing that as judicious as we can, at the same time assertively, to get the priorities done. The priority right now is long-term care, residents and staff done as soon as possible. So we're pushing that. At the same time, encouraging members of the public who have any symptoms compatible with COVID-19 to go to their assessment centers and to be assessed and get tested as the assessment centers determine, and do that in that regard. So it's open for lots of testing. The latter one with the assessment centers is dependent on the public who feel they need to come and get tested, and that in some sense seems to be easing off, which fits with our numbers coming down. Meanwhile, the assertive testing in the long-term care home is part of our overall response, as I said, related to our incident management system committee under Dr. Kevin Smith.
Follow-up?
Yes, thank you. The next question is, we have been through the long-term care spike, congregate living. What about congregate working? We're seeing increasing numbers of cases and plant shutdowns in food processing plants, meat plants, other plants. How much does that concern you, and are you expanding testing there?
That would be on our aspect of outbreak management. And if we do see a cluster in a plant, meat or other processing or companies or manufacturing, we would want to address that to look at, as we always do in an outbreak, what is the epidemiology in it? How was it spread? Was it a person introduced it? Is it the lack of proper infection prevention control practices, especially in the COVID reality we face now? Is there spacing and distancing of the staff throughout the day in that location? Is there potential spread through other means? So there's a number of components we want to look at there to assess the genesis of the outbreak and its progression, and to put in steps in place to stop at the outbreak and that it doesn't happen again. So I found each outbreak in some of these settings is unique and different and has to be addressed accordingly.
Next question.
Your next question comes from Randy Rass with CHCH-TV. Please go ahead.
Yeah, hi, Doctor. I'm wondering, all along you've been saying that people shouldn't go to their cottages, that they simply shouldn't do it. I'm wondering what is wrong, what harm there is if a family goes to their cottage, takes everything with them, doesn't shop locally, stays to themselves, and then get back in their car and come home. What harm is there in that?
Well, I think you raised it's a good point. It's part of the discussion, and we're waiting to see if there's any stance from a provincial side on that one there, because again, I call this proper social responsibility, and my word social distancing in that regard. And it's the same as we ask people to do down here, or people up in the far north or wherever you are, that you would do the same things. And the question is, as you've raised, if you're doing and you're doing it diligently, you're only going out for certain reasons, essential need to go, you're maintaining your distancing, you're bringing all supplies, you're not using up supplies in the local community, you're not going up ill, you haven't got any conditions that would overtax the local health system, which hasn't ramped up yet for the summer season, and doing that in concert with the local municipalities that would feel at least assured that that was occurring okay, and they're looking at some indicators. Is it not occurring? Much like we do down here, we look to see if there's any movement on less adherence to our standards. So I think my approach would be asking Ontarians, wherever you are and whatever your context, to be responsible, to be respectful, and to be careful in that, because you're doing that not because you're doing it as some sort of an issue, you're doing it because you want to adhere to it, to not put those communities at any risk at all, not put any pressure on those communities, and to understand why they're concerned because of their limited capacity this time, and because you still want to build that strong relationship. I think as a number of people who have cottages have a strong love for those local communities that they tend to make it their place of residence for a period of time in the summers in the past, and only would want the best for those communities because they've become to like them very much, and especially the citizens and communities and local retailers, that they want to continue to have a positive relationship on a go-forward basis during COVID and after COVID.
Follow-up?
Be the messaging that's coming from the province instead of simply saying don't do it and creating conflict between people that live in the cottage communities and cottagers?
I think that's the kind of messaging, if it was going to come, it would come from either our minister or the cabinet or the premier in that regard. We'll give some guidance directions on that, and I know our local medical officers are trying to deal with that tension with sometimes some of the municipalities are concerned, and what's the right balance in there to not only ask that, but to seek to ensure that that kind of respect and not misuse or abuse of that at the right time is done, and done carefully. So I think we'd have to wait to hear if there's any announcements coming out from the government in that level.
Next question.
Your next question comes from Joanne Chinelli with CBC Ottawa. Please go ahead.
Hello. I am calling a little bit with a technical question. In Ottawa, to look at sort of the trends in our city on COVID-19, officials here are not using positive cases or lab-confirmed cases because the criteria has changed. As we test more people, of course, we're going to get more positive cases. Instead, they're looking at the number of hospitalizations because they say, that's never going to change. You can't fake hospitalizations, right? That proportion of people who are getting sick is always the same. So they're looking at that number to sort of give a more accurate, they say, idea of how the illness is progressing in the community. Are you guys looking at that? Why not use hospitalizations instead of the number of positive cases?
Well, actually, we have, and that was the point of our modelers. When they looked at the data, they said we're going to look at cases. It has its limitations because of the way the data flows and the timing in there. And, of course, you get the mix between the two groups, the community versus the long-term care at the moment. And they said you have to differentiate those. They're different. At the same time, they said we looked at the hospitalizations, we looked at the ICU admissions and the deaths. And they said in that basis, they watched both. And as you remember, they said the hospital ones peaked about a week and a half, 2 weeks ago now. And so not that we didn't regard those, we did. And so we've looked at that. And that has plateaued and slowly coming down in that regard, except for some of the more admissions, as I said, to the hospital due to long-term care transfers in that regard. So that was our first metric, and we wanted to know where our hospital is going to be overstressed, where we're going to max out our ICUs and our ventilators, etc. And it looks like we flattened the curve on that one, at least flattened and maybe coming down. So that's reassuring. So we have that capacity there, and you've heard some discussions about resurgence again of elective surgery and moving that up in that regard. So the hospital one is an important one. Right now we're past that, so then how do we do the cases in the community? How do we watch that curve, separate that from the long-term care one? So getting into more segmentation of the data and moving on to the next issue, and that depends on the community spread and the containment ability within that to handle any cases in the future, so we can progress on our public health measures, get our transmission number down, the R naught, down to well below 1, and aspects there. So if Ottawa wants to use that at the moment, that's fine. If others want to use some other case counts, we're looking at the composite for the whole province in that, and that's what the federal authorities are looking at as well. So people use different numbers. The main thing is are we comparing the same things? Is the data as clean, as accurate as it can be? And then how's that informing, one, ourselves, second, the government officials, and the premier, etc., as well as the public writ large, of how well the community is doing, how well long-term care is doing, how well retirement homes are doing, congregate settings, and hospitals and ICUs. So we're getting many data points, and I think different parts of the system, different parts of the government, and different parts of the public are interested in all those different points.
This follow-up is the last question.
Sure, and I mean, I agree, there's a lot of data is important to people, and interesting, but I am wondering, doesn't the hospitalizations from the very beginning give us a more constant idea of what's happening throughout the community? Because it's going to show you, because the same general proportion of people who are going to get very ill and go to hospital has been constant. So isn't that a better number than waiting for 2 to 4 weeks of just positive test cases to go down? Wouldn't it be a better sense of what's happening overall to look at hospitalizations going down?
Well, as I said, we are looking at hospitalizations going down. It would, if we thought our numbers in community are going down and hospitalizations were going up, we'd say something's wrong here. So I think your number, the idea is that we knew that was a certain percent, and we said from the get-go 6%, and then a certain 2% of those ICU, and that would seem to be consistent. So we showed that our general population morbidity and mortality was consistent that way. I think the challenge is as you get into the latter half, if we have put those protections around our long-term care facilities, our seniors and elder and vulnerable, a lot of the cases that are still out there that are continuing to transmit, as we've noted, are more on the pre-symptomatic. We have a few people with very mild symptoms, and that percentage of that group is not identified. And I think that 6% didn't include that number. And so the question has always been, are you really getting a sample of the population writ large infection and transmission? That's where we're looking at our transmission rates. And of course, we're asking the next question, are we going to be entertaining in sometime in the near future serological testing to see what was the real impact on the population and what immunity do we have in it? So I think it's all part of the puzzle and part of understanding the novel coronavirus, because before we were going totally with symptoms, full-blown severe symptoms. We started doing moderate symptoms. Now we're doing mild symptoms. We've widened the symptoms phase to things we didn't include in the initial one. So from one sense, we sampled across the board, and now we're going wider. So I think the public want to know how much transmission is actually going on right now, how much immunity is in the community. We don't know that for sure. That's the serological testing, because we're not talking about just today and the next few days. What's the next 6 months look like? What's the fall going to look like? Are we going to be out of this in a year from now? And it's all this looking forward and improving our metrics. So, one set is useful, but the more data we have and the better the data, the better our planning and assessing and rolling out a recovery, so we don't have to all of a sudden backtrack just the basis of one metric only.
Thanks, everyone.